Today's topic is oral candidiasis. Oral candidiasis is the most common oral fungal infection in humans. These infections are also called candidosis. Earlier, they were named moniliasis. Oral candidosis are frequently encountered in the practice of dentistry. Although most oral candidoses are symptomless, they can indicate the presence of an underlying systemic disease. Persistence of the lesion, even after appropriate conventional management, may be one of the first signs of undiagnosed immunosuppression. The Candida genus is comprised of over 150 species of aspergillus yeast-like fungi. They are ubiquitously distributed as saprophytes in soil and aquatic environments and as animal reservoirs. Several species are found as commensal microorganisms within humans, and these can act as opportunistic pathogens in debilitated individuals. Candida are called true opportunistic pathogens as they instigate oral infection only when there is an underlying predisposing condition in the host. So, Candida albicans are the species most frequently associated with oral infections in humans. Candida albicans, they live as harmless commensals in the gastrointestinal tract, mouth, nose, etc., and is found in over 70% of the population. Although yeast is generally harmless, it may cause disease when the skin is damaged or when the individual has a depressed immune system. Overgrowth of these organisms will lead to disease. So next is pathogenesis of candidiasis. The microbial composition of human mucosa is diverse and structurally complex. The oral mucosal cells act as the first line of defense against microorganisms and keep the host healthy. Infections caused by Candida are most frequently superficial. That is, they occur on moist mucosal surfaces in individuals suffering from a mild debilitation. The most prevalent Candida species involved in humans are Candida albicans. In oral candidosis, Candida albicans accounts for around 50% of the cases. The incidence of Candida albicans isolated from the oral cavity has been reported to be 45% in neonates, 45 to 65% of healthy children, and 30 to 45% of healthy adults. So, overgrowth of Candida can lead to local discomfort, altered taste sensation, dysphagia from esophageal overgrowth, resulting in poor nutrition, slow recovery, and prolonged hospital stay. So, what exactly happens is there will be overgrowth of yeast on the oral mucosa. This will cause desquamation of the epithelial cells and thus leading to accumulation of bacteria, keratin, and necrotic tissue. This will form a pseudomembrane which adheres closely to the oral mucosa. So, what are the predisposing factors for oral candidosis? First one could be changes in oral microbial flora due to administration of broad-spectrum antibiotics or due to impaired salivary gland function or xerostomia. Or it could be due to a local irritant like danger, which produces a microenvironment conducive for fungal growth with low oxygen and low pH. Or it could be due to an orthodontic appliance or even heavy smoking. It could be seen in corticosteroid therapy, which suppresses immunity, or radiation to head and neck region. It's also seen during diabetes or tuberculosis, or in infancy where there is immature immune function, pregnancy, or old age where there is depressed immunity. So, how do we diagnose oral candidiasis? In addition to proper medical history and physical examination, the physician must scrape off a sample and confirm diagnosis with a microscope or a culture. So, oral candidiasis is classified according to their onset and duration as acute and chronic, and based on their clinical features including color as pseudomembranous, erythematous, or atrophic, based on their location as median rhomboid glossitis as seen on the dorsum of tongue, denture stomatitis seen under dentures, and angulochelatous seen on lip commissures. are the presence of skin lesions or oral lesions, or it may be associated with an immunocompromised host like HIV patients. So first type is oral thrush. Oral thrush is a prototype of oral infection caused by Candida albicans. You can see superficial infection of the outer epithelium. Patchy white plaques or flecks will be seen on the mucosal surface. It is seen in children and adults of all ages. General rubbing or scraping can reveal areas of erythema. So pearly white or bluish white plaques are present on the oral mucosa and they resemble cottage cheese or curdled milk. So a pseudomembranous lesion, that is a lesion which can be scraped off, will diagnose oral thrush. On microscopy, we can see localized superficial inflammatory reaction, hyperparakeratosis, ulcerations of the surface, and also a fibrinoid exudate with large number of yeast and pseudohyphae. Next form is acute atrophic candidiasis. So the antibiotic sore mouth is the most common form of atrophic candidiasis. Acute candidiasis means candidal infection which is of acute onset or sudden onset. So antibiotic sore mouth is a common example for atrophic candidiasis. So when the white plaques of pseudomembranous candidiasis is removed, we can usually see a red atrophic and painful mucosa. And the symptoms include oral burning, bad taste, sore throat during or after therapy with broad spectrum antibiotics. And this condition is usually seen in AIDS patients or patients receiving prolonged drug therapy using topical steroids or broad spectrum antibiotics, or also seen in patients with iron deficiency anemia. Next form is chronic atrophic candidiasis. The chronic form of candidiasis, it involves angular cheilitis, dengue and median rhomboid glossitis. So inside that, first one is dengue stomatitis. Dengue stomatitis is usually found under complete dengue or partial dengue. As in the figure, you can notice that the redness is sharply outlined and restricted to the tissues in contact with the dengue. You can see diffuse inflammation of the maxillary dengue-bearing areas, usually of the hard palate and the alveolar ridges. So there are three progressive clinical stages for dengue sore mouth. The first stage is we can see numerous palatal petechiae. And the second stage you can see diffuse erythema including most but not all of the dengue-bearing mucosa. And the third stage you can see development of papillary hyperplasia. That is tissue granulation or nodularity will be seen involving the central areas of hard palate and the alveolar ridges. On the last picture, you can see diffuse erythema of the dengue-bearing areas. The next form, chronic form of candidiasis is angular cheilitis. Angular cheilitis is also called perlicay or angular chelosis. So as the term implies, it affects the angles or commissures of the mouth. In the picture, you can see bilateral presentation, which is most common, but unilateral presentation is also seen. So this condition is frequently associated with dengue stomatitis. So angular cheilitis is seen due to overclosure of the jaws in edentulous patients or in patients with artificial dentures which lack proper vertical dimension, or it can be seen also due to nutritional deficiency. So what happens is wrinkles or folds are produced at the corners of the mouth. At these areas, saliva tend to pool, and these areas of skin will become macerated, fissured, and secondarily infected, leading to angular cheilitis. Next is median rhomboid glossitis. As the name suggests, it is seen at the middle portion of the dorsum of tongue. So originally it was thought to be a developmental disorder of the tongue, but now it is considered as a manifestation of chronic candidiasis. So we can see erythematous patches of atrophic papillae located in the central area of the dorsum of tongue. When these lesions become more nodular, this condition is referred to as hyperplastic median rhomboid glossitis. Next chronic form is chronic hyperplastic candidiasis. So this condition is also referred to as candidal leukoplakia due to its appearance. It is considered as a chronic form of oral candidiasis. We can see firm, white, leathery plaques on the anterior buccal mucosa proximal to the anterior commissures. You can see in the first picture, white leathery plaques on the left commissure of the lip. So that is the most common site. The second most common site would be the lateral border of the tongue, where we can see in the second picture well demarcated, raised, fissured white plaques that are non-scrapable. So hyperplastic candidiasis are non-scrapable lesions, and this infections are of highest prevalence in middle-aged smokers. And this could be either homogeneous or speckled form, and this infection tend to be asymptomatic. So an important consideration for chronic hyperplastic candidiasis is that these infections have an increased risk of malignant transformation up to 10%. The differentiation of candida leukoplakia from other forms of leukoplakia is based on finding positive hyphae on periodic acid shift staining. As in the picture, you can see the presence of hyphae on periodic acid shift staining. Histological examination is indeed the diagnostic tool for this infection. If this condition occurs on the dorsum of tongue, so it may resemble median rhomboid glossitis. Next form is chronic mucocutaneous candidiasis. As the name suggests, it occurs both on the mucosa and also the skin. So it occurs mainly as a result of defect in the cell-mediated immunity, that is due to the improper functioning of T lymphocytes, or it may be associated with iron deficiency. So this condition is characterized by widespread occurrence of superficial candidosis of the skin, which is seen in the first picture, or of the nails. You can see candida infection of the nails in the third picture, or it could be seen on the mucosal membranes, including that of the oral mucosa. As in the second picture, you could see white plaques on the feet. So following are the prominent lesions that can identify chronic mucocutaneous candidiasis: the presence of hyperplastic mucocutaneous lesions, localized granulomas, and adherent white plaques on affected mucous membranes can diagnose a chronic mucocutaneous candidiasis. So next form will be immunocompromised HIV-associated candidiasis. Oral candidiasis is the most frequent opportunistic infection associated with immunocompromised individuals. So patients on immunosuppressive drug regimens or HIV-infected patients or hematologic malignancies have increased susceptibility to oral candidiasis. So how do we manage oral candidiasis? Assessment of predisposing factor plays a crucial role in the management of candida infection. Acquiring a proper medical history is therefore an essential component in the management process. Usually, candidiasis is effectively treated with topical antifungal ointments. However, in cases with chronic immunosuppression, systemic antifungal medications are required. So the treatment should be maintained for 7 days. Oral lesions and symptoms usually disappear in 2 to 5 days, and relapses are common due to underlying immunodeficiency. It will recur if underlying cause is not removed. So the first step in management of oral candidiasis will be removal of the underlying cause. And next, topical treatment, which includes clotrimazole 10 mg dissolvable tablets or nystatin preparations can be used as oral rinse, or amphotericin B 5 to 10 ml is also used as an oral rinse. A systemic treatment includes ketoconazole 200 mg tablets once daily for 1 week, or fluconazole 100 mg tablets once daily for 2 weeks. To summarize the types of candidiasis, the first one is oral thrush, which is a prototype of oral candidiasis. And oral thrush is a pseudomembranous lesion. That is, the lesion can be scraped off, and we can see areas of erythema. The next is acute candidiasis, which means a candidal infection which has a sudden onset. So, a most common example is an antibiotic sore mouth. The third form, chronic candidiasis. It includes median rhomboid glossitis, which is seen on the dorsum of the tongue, or angular cheilitis, as the name implies, it is seen on the commissures of the mouth, or dengestomatitis, seen in areas of dengue mucosa. So the next one is mucocutaneous candidiasis, which means it involves the mucosa and the skin. And candida leukoplakia, or chronic hyperplastic candidiasis. It resembles leukoplaskia and has a malignant transformation rate in up to 10% of cases. So a periodic acid shift staining or a histological examination is a diagnostic tool for candida leukoplakia. And the last one would be associated with an immunocompromised host like HIV patients. So to conclude, Candida albicans is a highly adaptable microbial species capable of causing infection at various anatomical sites. Local innate immune defenses play a central role maintaining Candida in its commensal state. Management usually involves taking a proper history, an examination, appropriate antifungal treatment, and laboratory analysis. The prognosis is good for oral candidiasis with appropriate and effective treatment. The clinical significance of oral candidiasis, either as an independent disorder or as part of another disease, is increasing with time. Therefore, this disease cannot be eliminated without correct diagnosis and management of the underlying disease. Thank you.